Hello everyone, I'm Dr. Sneha and today I'll be discussing the recall questions from NEET 2021 in the subject of obstetrics and gynecology. Before I start, I would like to just tell that these questions are collected by memory-based method through recall, and so some of them might not be correct, and based on that I have chosen the answers. So if there are any changes, open to discussion. Okay, so let's start. The first question, the patient is in her second pregnancy and first pregnancy was twin delivery. So what is her obstetric score? Obstetric score is a very important question in OG. You can expect it in almost every exam. So just two principles that I want to explain. First, when looking at the obstetric score, you have gravida, para, live and abortion. So gravida is the only option that includes the present pregnancy as well, whereas para, live and abortion are all of the previous pregnancy. This includes any pregnancy, gravida includes any pregnancy events like normal pregnancy, ectopic or miscarriage as well. The second point is gravida, para and abortion are number of pregnancy, whereas live is the only parameter that looks at the number of children, alive children. So in this case, she is in her second pregnancy, so that means G2, and first pregnancy was twin delivery. First pregnancy is one pregnancy event even though it's twins, so it will become P1. If this question had L2, this will be the best option. So the answer here is G2P1, and in case if live was given, it will be L2 because it's twin, there will be two live children. The next question, 24-year-old who's come with 6 weeks of amenorrhea. She is stable and has a left adnexal mass of around 3 cm on ultrasound. There is no fetal heart rate and the beta HCG is around 2800. So what will be your management? So let's look at the management of ectopic pregnancy briefly. So when you have diagnosed an ectopic pregnancy, there are basically 3 ways you can manage. First is expectant, where you don't do anything, you just follow up the patient. Second is medical management, where you give methotrexate. And third is surgical, where different options are there. So first, you have diagnosed ectopic. Next is check if the patient is stable vitally or not stable. In the question, the first step is you check if the patient is stable or unstable. If unstable, it becomes very easy for you. The management is surgery. If it is stable, the next thing to see is if they have given any ultrasound findings. If the patient has gestational sac of more than 3.5 centimeter, or if cardiac activity is present, if there are any fluid in the peritoneum, if any one of these is present, again you go for surgery. If all of these 3 are negative, next you look at the beta HCG value. So beta HCG value, if it is less than 1000, you go for expectant management. If it is 1000 to 5000, it is medical management, and if it is more than 5000, you go for surgical management. So first thing, check if the patient is stable or not. Second, look for any ultrasound findings. If any of these 3 is present, go for surgical. If none of them are there, look at the beta HCG value next, and according to that you can choose which type of management. So let's look at, in this case scenario, the patient is stable, first point. Second, look at any ultrasound finding. She has a left adnexal mass of 3 cm, no cardiac activity. And as far as this question goes, there is no fluid in the peritoneum. So the next step is to look at beta HCG. Beta HCG is around 2800. So that lies in this range, 1000 to 1500. So our option will be medical management, which will be injection methotrexate. The next question, this is a bit of a controversial question. Uterine diadelphys, least common complication. Recurrent abortion, preterm labor, transverse lie, endometriosis, all are known complications that are seen with uterine anomalies. So we need to see which is the least common one. Let's look at it one by one. So let's start with preterm labor. Any uterine anomaly, there is a chance of cervical incompetence and preterm labor. So we can exclude that. Transverse lie, for any pregnant lady, you need to have a broad fundus above and then a narrower lower segment. That's why the breech comes at the top and the head comes at the bottom in a normal lie. When this shape or the polarity of the uterus is lost, as seen in uterine diadelphys, where you can see two uterus, two cervix, and a vaginal septum in the center. This is what you normally see. So the normal curvature of the uterus is lost, so there is a chance for abnormal presentation such as transverse lie, breech, anything other than cephalic. So this is out of option. And endometriosis. Now if you look at you might argue that most of the non-obstructive uterine anomalies such as diadelphys, endometriosis might not be possible. But when you look at this vaginal septum sometimes can cause obstruction when the septum is attached to the vaginal wall like this. So the blood gets collected here, and by retrograde black flow, by Sampson's theory, it can cause endometriosis. So recurrent abortion, you might argue with me that abortions are common with all uterine anomalies. So I have a reference for you. So this is a reference from Williams' 4th edition, which is the latest edition of Williams, under the heading of uterine diadelphys. So if you see here, they say that uterine diadelphys has probably improved blood supply because they have collateral supply from the other horn. So the blood supply is actually better. And also the spontaneous abortion rate is equivalent to women with normal uterine cavity. So in the recent literatures, it is seen that the rate of abortion is actually not that much compared to the normal patients with normal uterus. So, so this is why I have chosen recurrent abortion as an option. So this will be the least common complication. The next question, 16-year-old presented with dysmenorrhea and chronic pelvic pain and has a transverse vaginal septum. So the diagnosis. So as already discussed in the previous slide, a transverse vaginal septum here, patient presents with dysmenorrhea and chronic pelvic pain. From the symptom, usually dermoid cyst does not present with any of these systems. Most of the patients with dermoid cyst will be asymptomatic, found out by ultrasound, or they'll have a vague abdominal pain or severe abdominal pain if they come with torsion. Fecal lutein cyst, again same presentation, mild abdominal pain or increased abdominal pain, heaviness. Tubo-ovarian action patient will have abdominal pain, fever, abnormal discharge, all the signs of infection. So this is out of the option as well. So from this you can rule out and come to endometriosis. The bonus point is the patient has transverse vaginal septum, so there is a block here. So again, by retrograde flow of the menstrual fluid, it can, by Sampson's theory, it can cause endometriosis. So the answer is endometriosis. The fifth question, again a controversial question here. Molar pregnancy which was treated 6 months back. The patients come with bleeding PV, high beta HCG and cannonball lesions in the lungs. So the diagnosis here is pretty straightforward. It is choriocarcinoma. So now what to do if it is choriocarcinoma? Now depending on by stratifying it as low risk or high risk, you can either give single agent, usually we use methotrexate or actinomycin, or the combination treatment which is Emaco. So this I have taken from Novax. So let's just go step by step. So you've diagnosed it as GTM and choriocarcinoma. So the next step, is to see if there is any metastasis anywhere else. In this patient, it is given as lung metastasis, so that becomes stage 3. Now the next step is calculate risk. When you look at stage 1 disease, all of them will automatically be low risk and you give single agent. And again, when there is stage 4, it will automatically be high risk and you have to give combination. The stage of the disease and risk scoring is two different things. Staging is to see if there is any metastasis. Risk scoring is to decide what kind of treatment you are going to give to the patient. Now, based on the risk of the patient, you decide whether it is low risk or high risk. If the scoring is equal to or less than 6, it becomes low. Equal to or more than 7, it is high. And for low risk, you give single agents such as methotrexate or actinomycin. And for high risk, you give combination, that is imaco. Now, so this is the basic outline. So in this patient, I'm not sure if more information was given, but actually just with this information you cannot score, and without the scoring we cannot decide whether it is methotrexate or imaco. But with whatever information is given, if we try to do the scoring, the previous pregnancy was mole, so that is 0, and the interval from treatment is 6 months, so that will be 1, and the site of metastasis is lung. So with whatever it is given, the score just comes to 1. So I would still say go with methotrexate treatment and not with imaco. If you guys remember any other information that was given for this question, we can modify the answer accordingly. So the next question, the patient is taking ATT for pulmonary tuberculosis and OCP for contraception, but she was asked to take additional contraception because of interaction with which drug? So of all the ATT drug, rifampicin is an answer. It is an enzyme inducing drug. So it can alter the metabolism of OCP and make it less effective. So there can be failure. So it is better to change the contraceptive or use an additional contraception such as barrier method. Next question. Again, based on contraception, a patient has forgotten to take 4 different pills on 4 different days in the past 2 weeks. So what do you advise the patient to do now? So missing contraception pill can be quite a confusing topic. So I'll just briefly explain how you go about this. Before that, the basics first. So when you start taking OCP, so for the first 3 weeks, you take the pills. And then the 4th week, we call it the pill-free interval, where you don't take the pills, or in some packets, there will be placebo tablets or iron tablets, 7 tablets. And then as soon as this pill-free interval or 7 tablets is over, from the next day itself, you start taking the next pack. So this is how you take the OCP pills for contraception purpose. And 3 important principles in OCP. First, it is very important that you take the pill on the first day after the pill-free interval and do not increase it for more than 7 days. On the 8th day, that is after 7 days of pill-free interval, you have to start it on the first day. Second, it is quite important to take the pill in the first week without fail, without missing the pill. Now both this point is important because if you remember from physiology, it is in the first week that the follicles get recruited and they become big. One of them forms Graafian follicle and then causes ovulation. Since OCP acts by preventing ovulation, and this is the reason why it is important, these 2 points are important. You start it on day 1, that is immediately after the pill-free interval is over, and it is important to take the first 7 pills of the first week continuously without fail. And the third principle is that for the OCP to be effective, to start acting, you need to take it for 7 days consequently, that is continuously. So keeping these 3 points in mind, let's look at how missed pills are managed. Broadly, you can divide it into missing 1 pill or missing 2 or more pills either continuously or on different days. Suppose if you miss 1 pill, or if you start the first pill late by 1 day. For example, you're supposed to start it on Monday, but then you remember it on Tuesday. You can take the forgotten pill immediately, missed pill, and take that day's pill also. So if you remember it on Tuesday, you take Monday and Tuesday's pill together on Tuesday. And continue with the same packet, and you do not need extra contraceptive method. And no need to take emergency contraception if you have had unprotected intercourse at this point. So this should not be a problem. Now when you miss 2 or more pills, your concern is whether your contraceptive effect is there for the subsequent weeks. That is the first question. What about the next few weeks? What is the contraceptive effect for that? And the second question is, if you have had unprotected sexual intercourse during the period you have missed the pills, are you at a risk of becoming pregnant? So do you need emergency contraception? So you need to answer these two questions. So for the first question, if you have missed 2 or more pills, or if you have started the first pill, the day 1 pill, 2 days later, you take the most recent missed pill along with that day's pill, continue with rest of the pack, and see, this is where the third principle becomes important. You should take the pill 7 days continuously for it to start having some effect. So you take the pill 7 days consequently. The next 7 days becomes important. Take the pill next 7 days consequently, and during this time use other contraceptive methods like barrier so that you're protected during this. Once you take the pills for 7 days continuously after missing the pill, your protective effect becomes more. So next, if you have had unprotected sexual intercourse during the time you missed the pill, now you have to look if the patient has taken 7 pills consequently in the previous week. So if she's taken 7 days previously, that means even if she's missed the pill, she has some amount of protection. So for this, you need to look at which week she's missed the pill, whether week 1, week 2 or week 3. Now if you look at week 1 in this diagram, week 1, the previous 7 days, if you notice, it is the pill-free interval. So she has not taken 7 consecutive pills in the previous week. So here you need to use emergency contraception if she's had sexual intercourse without and missed the pills. In week 2, if you see, in week 2, the previous first week, if she has taken the 7 pills correctly in this first week, she does not require emergency contraception. But if she has missed any pills and there is no 7-day consecutive intake, she will need. So it depends on how she's taken the pills in the first week. In the third week, again the same thing. If she has taken the pills in the second week properly, all the 7 days, she does not require. If she has missed any pills here, she needs to use emergency contraception. So, but remember, in the third week, it is followed by the pill-free interval again. So for your contraception to be effective after she has missed the pill, if you remember, you need to take it 7 days consequently. So instead of taking this pill-free interval, you dispose this pack and start the next pack immediately so that you can take 7 pills consequently. I hope it's not confusing. So the important thing is, for protection in the subsequent weeks, you have to make sure that the patient takes the pills in the next 7 days properly. To see if she needs emergency contraception, if she's had sexual intercourse during the time she missed pills, check the previous 7 days if she's taken the pills properly. So that's the broad outline. Now coming back to the question, she's missed 4 different days in the past 2 weeks. So probably the first 2 weeks. So if you look at this option, continue as per schedule, additional contraceptive method, if they've given 7 days, yes, that would be perfect. And consider emergency contraception, that is also correct, because we do not know which 4 days she missed, and so whether she's taken the previous 7 days properly. So option D will be the right answer. So the next question, what is the treatment for uterine septum? So I think there's some confusion in the option hysteroscopic metroplasty or hysteroscopic uterine septal resection, laparoscopic metroplasty. Metroplasty basically means a surgery that is done to reconstruct a uterus that has a uterine anomaly to make it look like a normal uterus. It can be any uterine anomaly, a septum, bicornuate or didelphys, any uterine anomaly. So the important point here is it should be done hysteroscopically because septum is something that is seen projecting into the endometrial cavity. You cannot see the septum if you view it through laparoscopy. You need to view it through hysteroscopy, then you can see the septum. So the answer will be hysteroscopic metroplasty. If you had an option of hysteroscopic uterine septal resection, that will be better because you are specifying what kind of metroplasty you are doing. You are removing the septum. So if this was the option given along with these two, this would be a better option. Next question, at 36 weeks primigravida comes with painful lesion on the vulva alone, herpes, probably herpes. What is the management? So active herpes lesion, there are two types, active and recurrent. If it is recurrent, the chance of infecting the fetus is very remote, so you do not have to worry about the mode of management. She can be managed like a normal antenatal patient. But if she has active lesions, look at the gestational age. If she is in the first or second trimester, you treat the herpes with acyclovir. Start her on suppressive dose, that is she has to take acyclovir every day till 36 weeks to prevent another infection from happening, and then you can tell her she can have a normal vaginal delivery if there is no other contraindication. If this herpes happens in the third trimester, 6 weeks, the last 6 weeks of pregnancy or during labor, then there's a high chance that the infection can spread to the baby. So in which case, again, you have to treat the lesion first and you need to offer her for an elective cesarean section so that the baby does not get the disease. So here you can see the patient is 36 weeks in the last trimester and she has herpes, active herpes. So the answer will be to give acyclovir and to plan for an elective cesarean section. Question. A 38-year-old presented with history of recurrent abortion. The first is at 8 weeks, 11 weeks and 22 weeks. It is at increasing gestational age. And again, cardiac activity was seen in all. History of preeclampsia and the last pregnancy. So what will be the probable cause of recurrent pregnancy loss? So when you come to any question with recurrent pregnancy loss, TORCH is always not an option. When you get an infection such as TORCH, your body develops immunity. So in the subsequent pregnancy, you will be protected by that immune bodies. APLA, genetic causes, syphilis, all these three, syphilis provided you have not treated the syphilis, all these three can be causes. In case of APLA, yes, there will be miscarriages, but APLA causes microthrombi in the placenta, so reduce blood flow to the baby, and so the baby will eventually die at different stages of pregnancy, so the cardiac activity will not be seen. So you can rule out, and mostly they will give a scenario where the antibodies are also present. Genetic causes, again, there is no other than the gestational ages and the preeclampsia history, there is nothing suggestive of genetic causes, and usually if the baby has genetic cause, all the three recurrent abortions usually happens in the first trimester, again without cardiac activity. So this is also ruled out. Third is syphilis. Syphilis, if you remember, there's a law called Kasowitz law where it says that if you keep getting pregnant with syphilis, the subsequent pregnancies has better outcome, or the subsequent pregnancy, the presentation will be later. So that is what is seen. First will be 8 weeks and then the second was little later at 11 weeks and the third was at 22 weeks. And since it's an infection, it does not cause sudden death of the patient, sudden death of the fetus unless it has progressed for a very long time and affecting the fetus. And preeclampsia, again, syphilis causes placentalomegaly because of inflammatory changes, and this can lead to preeclampsia. So in this case, syphilis will be the best option. Next question, a woman has hypertension and she is planning to conceive. Which drug has to be stopped? This is one-liner, pretty straightforward. Calcium channel blocker can be given, alpha-methyl dopa can be given, labetalol in fact is given very commonly. The correct answer is AC inhibitor. This is category X drug. It can cause teratogenesis in the baby. Mainly it affects the renal system. It can cause renal agenesis. So the baby produces less urine and there will be oligohydramnios, and because of oligohydramnios there can be multiple sequences, and the baby's kidney is also affected, so it causes teratogenesis. You need to avoid both AC inhibitors and ARBs in hypertensive drugs. The next question, a patient who's on OCP conceives, another OCP question. And which is the best modality to calculate the gestational age? I think this question was something like she was on OCP for the past 5 or 6 months and she's pregnant. So how do you calculate? So whatever it is, always the best and the most accurate method is CRL, which is usually done in the first trimester up to 13 plus 6 weeks. It is around 99% accurate. Whereas even with patients of normal periods, LMP can sometimes be wrong. So whatever the scenario is, if they ask what is the best modality to calculate the gestational age, always choose crown drum length by ultrasound. It is the most sensitive method. There's a question that patient had a delivery followed by amenorrhea, failure to lactate, and multiple transfusions. Multiple transfusions probably because she had PPH. So PPH can cause, severe PPH can cause reduced blood flow to the pituitary and cause Sheehan's. And because the pituitary is affected, all the hormones that is produced from the pituitary will be suppressed. That's why you have amenorrhea, because FSH and LH are not produced, failure to lactate because the prolactin is not produced. So Sheehan is the answer here. Next question, 36 weeks pregnant woman, valve replacement, I think it is mitral stenosis, who's on warfarin. What do you do next? So any patient who's on anticoagulant for any reason, previous DVT or patient on valve, usually in pregnancy, they will either be on warfarin or heparin. Heparin can be unfractionized or low molecular weight heparin. The usual regimen is first trimester they will be on heparin because warfarin can sometimes have effects on the fetal development. The second trimester they will be put on warfarin again because warfarin is a stronger anticoagulant and the chances of having thromboembolism is actually less with warfarin compared to heparin. In the third trimester, when the patient is on warfarin, you need to switch it back to heparin. The reason being warfarin has a longer effect of action of around 3 to 5 days. So suppose if this patient goes into labor the next day and you stop warfarin, the effect of anticoagulant effect will be there for the next 3 to 5 days and the patient might bleed. With heparin, when you stop heparin, it will have action only for the next 6 hours. So it is easy to plan your delivery and the patient will be off anticoagulant only for the 6 hours. So the risk of thromboembolism when the patient is not on anticoagulant is also less with heparin. So you can stop it before 6 hours and after delivery if you want to start, again the effect will be immediate with heparin. So this is the reason why you need to switch over from warfarin to heparin close to delivery around 36 weeks so that you can plan your delivery. You can stop it 6 hours prior to the planned delivery and restart it after the delivery. So the answer will be replace warfarin along with heparin. I think there is an option with aspirin as well. Aspirin is not usually given in pregnant patients for anticoagulant purpose when for the patient with valve replacement or previous DVT or such reason. Usually it's warfarin or heparin. So the next question, pregnant woman complains of urination while coughing and sneezing and cystocele is also present. Any incontinence associated with increased abdominal pressure events such as coughing, sneezing, laughing, it is always stress incontinence. If the scenario is like the patient had to rush to the toilet, then it is called urge. she has a strong sensation to pass urine, which she cannot control. That is called urge. So if she has both stress and urge, it is mixed incontinence. So the answer here will be stress incontinence. Next question. A niece of a pregnant woman nearing term has got chickenpox, varicella, and the pregnant woman has tested antibody for varicella and it has come back as negative. So when antibodies are negative, it means she's not had that disease previously, and so the body has not started producing antibodies to that disease. So that means she's susceptible to chickenpox. So the answer will be susceptible to chickenpox. Next, on a pregnant patient, while doing her abdominal examination, there is flattening of infraumbilical portion. The fetal heart rate is heard on the flank region, left flank region, and she has urge to bear down, that is premature straining. So what is the position of the fetus? We're quickly going through what occipito-posterior and where you can hear the different heartbeats for different positions. So if you see the nice round curvature of a pregnant woman is actually formed because of the baby's spine, the heart structure. And when the spine is anterior or slightly on the left anterior or right anterior, you get that nice bump. But when the baby's spine is backwards, posterior, the limbs are in the front. The buttocks, which is in the top portion, will produce some amount of curvature, but then because there are limbs, they are not actually round structures, so there will be a sudden flattening below the umbilicus. So this is why you get subumbilical flattening in occipito-posterior. And even though it is cephalic, when compared to the occipito-anterior position, because the cardiac activity will be somewhere close to the spine here, whereas in anterior position it will be closer to the abdomen, whereas in posterior position it will be closer to the mother's spine because the fetal spine is backwards. In any OP position, you need to keep your stethoscope or the fetal Doppler towards the mother's flank to hear it well. Occipito-anterior, it will be along the spino-umbilical line. And in breech, that is sacral, left sacral or right sacral, because the head will be here, the cardiac activity will either be, buttocks will be in lower down, it will be above the umbilicus. Whereas in transverse position, the baby will be lying like this, not in the longitudinal but in transverse place. So the fetal heart will be somewhere here in the center. So you will be hearing the fetal heart in and around the umbilicus. So these are the different positions where you can hear the fetal heart rate for different positions. So in this question, flat umbilical line, FHR on the left trunk and urge to bear down, all are classical features of occipito-posterior. Next question, which vessel carries the deoxygenated blood back to the placenta in fetal circulation? In fetal circulation, the artery and vein nomenclature is opposite to what we see in adults. So from the placenta, the umbilical vein takes it to the heart, and from the heart, the umbilical artery brings back the blood to the placenta. So this is oxygenated blood from the placenta. This is deoxygenated blood from heart back to the placenta. So the answer is umbilical artery. Next question, an infertility patient, she's undergone an ultrasound. It is your doubting whether she has an uterine anomaly. What is the best way to confirm diagnosis? So you have a suspicion, you want to make sure that she actually has. So that would be hysterolaparoscopy, because seeing is believing. So both in hysteroscopy and laparoscopy, you're actually seeing the uterus. Hysteroscopy by inserting into the uterus and see if there's any anomaly inside the uterine cavity, and laparoscopy outside the uterine cavity. So you need to do both so that you can combine both the findings and see what kind of uterine anomaly she has. So a picture like this, and what is the investigation? This is also a simple question. It is HSG, hysterosalpingogram. So hysterosalpingogram, you'll see a picture of an X-ray with the pelvic bone, and there will be a cannula lower below, for example like this, through which the dye is injected, and uterine outline. And if there is no tubal block or no anomaly, you can even see the dye going into the tube and spilling into the peritoneal cavity. Whereas saline infusion salpingogram will be an ultrasound picture, and most of the time you will be, so if this is the outline of the uterus in the ultrasound, and this black portion is where the saline has entered. Usually when you do not inject anything, the anterior and posterior endometrium will be touching each other and there will be no space. But when you are injecting the saline, a space will be created and that will be shown black like this. So this is how saline infusion sonography looks like. Next question, a patient with primary infertility has two intramural fibroids of 2.5 and 7 centimeter, which is blocking both the ostia. The other infertility workup such as ovulation and semen analysis are normal. So for conception purpose, what is the management? So in this case, the tubal blockage is caused by the fibroids, and especially 7 centimeter fibroid is quite big. Even if the patient did not have a tubal blockage, if you're planning for IVF pregnancy, this can interfere with the embryo transfer. The embryo will not get attached to the uterus, so this needs to be treated definitely. So the answer here will be laparoscopic myomectomy to remove the fibroids. ART, not right now for this scenario. You can still remove the fibroids and see how it goes. Again, GnRH analog is to only to reduce the size of the fibroids pre-operatively when you are planning a surgery to remove fibroids, just to reduce the size of fibroids. And but when you stop GnRH analog, the fibroid will come back to its normal size. So not exactly an option for patients with infertility. And uterine artery embolization is for somebody who has completed family and doesn't want a hysterectomy, want to retain the uterus but want some kind of a treatment for her fibroid and bleeding. So in such patients, it's uterine artery embolization. You cannot provide it for patient with infertility. Next question, patient with PPH, medical management has failed. You're going in for surgical management. In what order do you ligate the vessels? So if you look at the blood supply of the uterus, the blood vessel that is directly supplying to the uterus is the uterine artery. So the first step is to ligate the uterine artery, and then there is a collateral branch, another supply, a minor supply from the ovarian artery. This is the ovarian artery, and this usually anastomized with the uterine artery in the corneal region. So with the uterine artery, if you do not still control the PPH, you can ligate near the cornea to ligate the ovarian artery as well. Even with this, if you think the bleeding is not controlled, you go to the main branch from which the uterine artery is originated. So that will be the internal iliac, especially the anterior branch, because the posterior branch supplies the lower limb. So anterior branch is responsible for supplying majority of the pelvic organs like the uterus, bladder and bowel. So you need to ligate the anterior branch of the internal iliac artery. So that will be the last resort. So first the direct branch that supplies the uterus, and then that supplies all these branches. A father has tested for paternal testing for twin babies. One and the result has come back as one of them is his son and the other is not. What is the diagnosis? So always a confusion between superfecundation and superfetation because it sounds the same. Theory wise, if you see, superfecundation means two ovum that is produced in the same cycle, but the ovum is fertilized by two different sperms. So therefore, two different sperms from the same person or different person. Whereas superfetation, first one ovum is released in one cycle, which is fertilized by one sperm, and then the next cycle another ovum is produced and that is fertilized by another sperm. So one pregnancy followed by another pregnancy. So superfetation is something that is not possible in humans. It is seen in animals, and this is why if you see cats and dogs, they have 10, 12 kittens or puppies. Superfecundation is seen in human beings. So if you can't remember, very confusing, just remember superfetation, that is multiple babies, or more common in animals, so this is not possible in humans. The answer here will be superfecundation. The next question, a patient is anxious to conceive, has white discharge PV, no itching PV. Her last menstrual period was 13 days back. So that means her white discharge is around the time, around 13, 14 days, around the time of ovulation in a regular cycle. So because she does not have itching, you can rule out candidiasis and trichomonasis because both of these has itching. Now bacterial vaginosis is a inflammatory condition of the vagina. This also does not have itching, but the patient will have grayish homogeneous discharge and it will have a fishy smell. So these are some of the buzzwords to look for in the question if you're suspecting bacterial vaginosis. So this will most probably be physiological. The answer is physiological. Okay, so the last question for today's discussion, a pregnant woman is given indomethacin. I think the question said at 36 weeks. So what will it cause in the baby? Indomethacin is an NSAID and it will cause premature closure of the patent ductus arteriosus in the baby. So it is important that indomethacin or any kind of NSAID should not be given in a pregnant lady more than 32 weeks because it can cause this complication. Indomethacin is a drug that is usually used to medically treat polyhydramnios, that is increased Liker or AFI in a pregnant woman, because this will cause reduced urine output by the baby, which in turn will reduce the Liker around the baby. So remember, it should not be given at more than 32 weeks because of this complication. So with this, we'll be ending the recall discussion for OBGYN. If you think that some of the questions, there are extra information that you can add, or if you think you have a better reference and so that if a better answer, please do let us know. We can discuss it again and come together on a better answer. Thank you very much.